Today's talk is going to be something which is very relevant to our day-to-day practice. So everyone who owns an ICU will know that the face of infections in the ICU is changing very rapidly. Gone are the times wherein our bugs were sensitive only to ceftriaxone or to Trazodone-Tazobactam. But nowadays, especially in the COVID era, all of us have encountered organisms which are even carbapenem resistant. So the talk is going to be focused on the scope, the prevalence, the clinical implications of resistant gram-negative pathogens, how to optimize your pharmacokinetic and pharmacodynamic parameters that impact the drug and dose optimization, and list lastly the current available and the pipeline treatment options for the management of gram-negative infections and how these drugs may be useful for optimal antibiotic delivery in clinical practice. So, no escape from the pathogens. Indeed, yes, there is absolutely no escape from the multi-drug resistant gram-negative bacilli that we all encounter in our day-to-day clinical practice. And we should know what are the therapeutic options as well as the algorithmic approach for the management of these multi-drug resistant organisms. So what is the acronym ESCAPE? The ESCAPE organism, it actually comprises of 6 nosocomial pathogens that exhibit a multi-drug resistant and high virulence. ESCAPE stands for Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter, Pseudomonas and Enterobacter species. And the treatment of these multi-drug infections poses a significant challenge in critical care units. So we have new terminologies to describe the extensively drug-resistant bacteria and the pan-drug-resistant gram-negative organisms. There are many novel antibiotics which are added in the armamentarium for the management of multi-drug-resistant GNBs, and the prudent use of these precious additions in our antibiotic armamentarium is important to ensure their longevity. So now this is what is the clinical significance. These MDR infections are a threat to therapeutics. They have a high mortality rate, they decrease the effectiveness of the drug, they are an easy target for immunocompromised patients, they are associated with prolonged illness, and of course they increase the medical costs. So now this is a very significant study. This is the EPIC study which was published in 2009 in JAMA. It was a very, it showed or it gave us the global prevalence of gram-negative bacteria in intensive care unit. Now it was a large study, it was a single point prospective study which enrolled almost 14,000 patients in one day, in almost 1,300 patients in the ICU at one day across 75 countries. And what they found out that globally the majority of our ICU infections are due to the gram-negative bacilli. Now out of these gram-negative bacilli, or out of the 70% of infective patients had positive cultures, 62% were gram-negative, and only 31% of these gram-negative patients in these studies were usually, or they were the Pseudomonas species. Now what were the sites of infection in EPIC study? It was mainly the respiratory tract, followed by complicated intra-abdominal infections, followed by the bloodstream infections. So just to brief you before we begin the talk, so it's all about how to identify the MDRs. So this is just a basic classification of the beta-lactamases. Depending on their activity, they are divided into the serine beta-lactamases as well as the metallo-beta-lactamases. Now the serine beta-lactamases are further classified into class A, class C and the class D, whereas the MBLs represent the class B enzymes. So why should we know them? Because we have the, if we can identify the kind of, or we have a phenotypic identification of the organisms, then fine-tuning of the therapy becomes easier. So in the class A, we have the usual extended spectrum ESBL producing organisms, or we have the KPC producing isolates. With class C, we mainly come across the AMC producing organisms. We'll come to the significance of this later on, because we know what drugs are to be used when we isolate these bacteria. With class D, we have mainly the OXA producing organisms, that is OXA 48, OXA 23, and many of us have been currently using ceftazidime, avibactam or azithromycin these days to treat our multi-drug resistant gram-negative pathogens. Whereas your class B, that is the metallo-beta-lactamases, they mainly consist of your class B enzymes. So now these mainly the prevalent mechanisms of resistance amongst the superbugs. Carbapenem resistance is a pivotal event in the generation of the multi-drug resistant organisms. And how are the carbapenem resistant occurs? It occurs due to the production of a carbapenemase, which acts as a broad spectrum beta lactamase. So what are the other mechanisms of resistance? Outer membrane modifications, efflux pumps, and finally resistance to colistin, which was chromosomally mediated for years, a plasmid mediated mechanism through mutation in the MCR gene. So now these are the common bacteria that we see in the ICU, and these are the common mechanisms of resistance. Now this is a very relevant Indian data published by Dr. Rajiv Somant sir. So basically it is the iconic guidelines, and this focuses on Indian data which carry the carbapenemase or the carbapen resistant infections. So why is it important for us? So these are 6 pooled studies which show that the rates of CRE infections is on the rise, and CRE carriage and the infection burden emphasize the endemicity of the problem in India. And unlike the West, wherein the KPCs predominate, in India it is mainly the OXA48 and the NDMs that contribute to the CRE phenotype. So it is very, very important for us to know the organisms that are responsible for causing the multi-drug resistant infections. So now when do you suspect a multi-drug resistant, or what are the risk factors for MDR organisms? So the risk factors are, first is previous stay in an institution wherein the rates of MDR infections are high, prior ICU admissions, high Apache score on admission, prior receipt of immunosuppressive agents, prior colonization of drug resistant isolates, receipt of broad spectrum antimicrobials and aminoglycosides and quinolones in the last 3 months, and high severity residents requiring hospitalization in the ICUs. So this was another study which was published by Hussain et al. Which showed which emphasized upon the risk factors to procure a carbapenem resistant Klebsiella pneumoniae, and these were prior fluoroquinolone use, prior carbapenem use, previous ICU admissions, or exposure to broad spectrum antimicrobials 1 month prior to the admissions. So now coming back to the surviving sepsis guidelines, what do they say? They say that in septic shock, the antimicrobials should be administered within 1 hour. So this is the newest recommendation, and this say that in septic shock patients, the right antibiotic has to go within 1 hour of presentation. So thus our optimal therapy consists of a right pathogen coverage, the correct dose, timely initiation of antibiotics, correct route, and all of them result in the right survival. So what do we know? So what do we first have to do is that choosing a right antibiotic is important. For that, know your bugs, identify the clinical syndrome, predict the possible microbial pathogens, predict the local resistance pattern depending on your institutional antimicrobiogram, use the correct dose, the correct duration, and ensure that the chosen antibiotic has adequate tissue penetration at the site of action, and then optimize the PK/PD parameters. So thus management of infections in the critically ill patient is a challenge, and dosing is a measure of drug, bug, and the mug. So these are the key players in the treatment of infections, and ensuring a perfect harmony in them results in optimal patient outcomes. So now we move over to the cases. So this is a 58-year-old lady who presented to us. She presented to us with sugars of more than 450. The patient was obtunded, patient was hypotensive. She was severely acidotic with lactates of 7, had acute renal failure, she was drowsy. So needless to say that this patient presented with urosepsis. Urine routine suggestive of 250 pus cells, she had bacteria, and her left flank was tender. So immediately from the CT, from the casualty, she underwent a CT, and as you could see that this patient had presented to us with emphysematous pyelonephritis. So yes, this is a medical emergency. So this was what her blood culture showed. CRE, that is a carbapenem resistant isolate. So you could see that she had a carbapenem resistant E. coli. Now believe me that these situations are becoming very, very common, wherein clinicians are left only with colistin or polymyxin B. But is there anything else which we can use to treat this patient? So what is the antibiotic of choice? This patient has a creatinine of 4.5. Colistin, polymyxin B, tigecycline, or gentamicin, or none of the above? Anyone? Kanishka, no? So anyone? What is the antibiotic of choice in these patients? Patient had emphysematous pyelonephritis, renal failure, and the isolate is grossly resistant to meropenem, very high MICs.
Colistin?
Yes, colistin is good, but however we should remember that this drug has got extremely variable pharmacokinetic and pharmacodynamic parameters, plus it can worsen the nephrotoxicity. Polymyxin B not at all good for your urinary tract infections because its penetration into the UTIs is not good. Tigecycline, the same concern. Gentamicin, already this patient has a creatinine of 4.5. So the answer is none of the above. Something else we should do. There is a test, and we are fortunate to have this CABA test in our institution. So this is a test which is a real-time test for the rapid detection of carbapenemase producing genes with a turnaround time of less than 24 hours. And this gave us that the carbapenemase producing organism expressed NDM and OXA48. So these enzymes were expressed by the isolate. So there is a novel drug which can be used here, and that is ceftazidime and avibactam in combination with azithromycin, which have excellent penetration into the urinary tract. So this patient was treated with a combination of ceftazidime and avibactam. Of course, the urologist was prompt, and she underwent a nephrectomy. So with severe pyelonephritis and with patient presenting with hypotension and shock, parenteral therapy is indicated. If the suspected organism is an ESBL producer, carbapenems or aminoglycosides can be used. If it's an AMC producer, 4th generation cephalosporin, carbapenem or aminoglycoside can be used. If it's a carbapenemase producer, I have given the flowchart in the next slide. For an uncomplicated UTI, the organism produces ESBL or AMC. Phosphomycin, Septran or ciprofloxacin can be used. And for CRE drugs, we still have phosphomycin in hemodynamically stable patients. Nitrofurantoin and orophosphomycin do not achieve adequate concentrations in renal parenchyma. So so this is the management algorithm for carbapenemase or carbapenem producing Enterobacteriaceae. For Klebsiella, ceftazidime avibactam with azithromycin. For Pseudomonas, unfortunately, we don't have lots of antibiotics. If it's an E. coli, colistin, phosphomycin, aminoglycosides or Zavicefta can be used. So what about the pharmacokinetic parameters? Colistin, good urinary presentation but develops resistance on monotherapy. Phosphomycin, excellent urinary levels. Cas-AV, good choice for CRE UTI. Now this was a patient who developed VAC. So this patient on cultures grew carbapenem resistant Acinetobacter, which again is the antibiotic of choice, colistin, amikacin, tigecycline. So always remember that despite of having sensitive levels on your cultures, these antibiotics do not penetrate into the lung tissues, or in an acidic medium they have a very poor penetration. So we have to always combine inhaled polymyxins or aminoglycosides. So this patient was a very sick patient with necrotizing fasciitis. The blood cultures grew ESBL Klebsiella, so which was sensitive to piperacillin tazobactam. So this patient was treated with piperacillin tazobactam and linezolid. But the patient after improvement worsened in 48 hours. So what was the rationale? Ideally, a carbapenem is preferred for treatment of complicated infections outside the urinary tract caused by the ESBL. So this was a very good trial which was published in JAMA 2018, and they recommended carbapenem as the first line of management for serious bloodstream infections outside the UTI. So this was the last case, a patient of an 80-year-old patient who had CLLs, who had multiple admissions in the hospital for recurrent UTIs. So this patient presented to us with a GI bleed. Initially did well, but the patient suddenly worsened on day 6, day 7. So remember, this patient was a patient of hematological malignancies, received chemotherapies in the past, had multiple admissions for UTIs. Now worsened, she was drowsy, tachypnic, ventilated, antibiotics were escalated, colistin was started, but the patient had no response to colistin also. So any reason you could think of? So yes, the blood cultures grew an unusual organism, that is Stenotopomonas maltophilia. So now this is a breakthrough infection which happens when a patient is on colistin treatment. So we always have to remember that if the patient has been in the hospital for a long time, has got indwelling devices, has been on parenteral colistin or broad spectrum antibiotics for a long time, then and is not responding to an appropriate therapy even with polymyxins, we should consider breakthrough infections with colistin resistant bacteria like Stenotopomonas. So this patient was treated with IV Septran and minocycline, but unfortunately she succumbed to GI perforation and sepsis. So just quickly, the IDSC 2021 guidelines for dosing or for the new drugs which have been in the pipeline for treating the MDROs. So zaviceftum with aztreonam, colistin, polymyxin still form a backbone of therapy. Eravacycline, which can be used for CREs, Klebsiellas and Stenotopomonas maltophilia. Phosphomycin, yes. However, the experts strongly discourage the use of monotherapy in CRE infections, and it is used in combination for salvage treatment of organisms due to metallobetyl lactamase producing organisms. And these are the drugs: imipenem, relebactam, ceftonozone, avibactam, ceftidurol. However, these are not available in India. So yes, this storm is preventable. Common strategies: contact precautions, isolation of the colonized patients, hand hygiene is of paramount importance, and antibiotic stewardship plays a very important role to prevent this storm of multi-drug resistant gram-negative bacilli. So thus, I end my presentation with a talk or with a saying: bacteria may not build cities, or they may not have interesting social lives, but they'll be here till the sun explodes, and it's their planet, and we are on it only because they allow us to survive. So thus, widespread use of antibiotics promotes the spread of antibiotic resistance, and smart use of antibiotics is the key to indicating its spread. Start smart and then focus. Use the right drug at the right place at the right time for a right duration. And thank you very much for your kind attention.